Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana. With me, as always, is Seamless MD's CEO, Dr. Joshua Liu. Today, we're joined by our excellent guest. We have Chief Digital Officer at the Guthrie Clinic, Terri Couts. Terri, welcome to the show.
Thank you.
Terri, you've had just the most exceptionally unique journey through your career. And I actually heard that you started your career as a teacher, but then soon realized that that wasn't the life for you and got into nursing. So I'm really curious, what motivated that shift and why healthcare and nursing in the first place?
Yeah, like most young people, we don't know what we want to be when we grow up. Early childhood, I wanted to be a physician. And when I got to college, I thought that I would take my passion and try to teach children. And I've learned very quickly within the first year of entering into the teaching profession that it wasn't for me. It wasn't what I anticipated. It wasn't as fast paced as I like, but I still had this desire to help people. So I went back to my original kind of plan, I guess, and went into nursing and started my career that way.
Oh, that's really cool. And then I believe it was an OR manager that kind of led you down the path of healthcare IT. Is that true? And what happened there?
Yeah, so I worked in pediatric heart. So I did both cath lab and open heart. And pediatric heart cases are very long and tedious cases. Every heart is different, and because they're born with their plumbing is just not routed correctly. And so it was like a puzzle that needed to be solved. But because we had such a small team, we had to be on call about 20 days a month. We had to be within 30 minutes of the hospital. And after several years of working in this field, it felt that I didn't have a very good work-life balance. I was looking for a change, didn't know what I wanted. And we had a nurse that was managing our software system, and it was GE actually in our OR. And he said, you should look into this Epic thing. It's going to be big. And I had no idea what he was talking about. But at the time, I worked for Akron Children's Hospital in Akron, Ohio, and they were getting ready to embark on implementing Epic. And they were looking for clinicians to help them configure Epic because at that time, Epic wasn't very pediatric friendly as far as content went. So they had to have a lot of development and customization. And so I interviewed for a role, for an analyst role actually. Had no idea even when I left the interview what I was going to be doing, but they offered me a job. And I'm a little bit of a risk taker in the sense that, if I figure let's try it out. I never close any door. I always listen to opportunities. And this was an opportunity that opened many doors for me. I didn't know it at the time, but that's how I got into IT. I started implementing Epic at Akron Children's and went into management and then went into consulting and just continued to take on additional scope and responsibilities.
I love it. It kind of reminds me of how it's very hard to predict the future for ourselves, for our careers, and you just kept saying yes to new things. I'm going to guess there probably were some things you said yes to that didn't maybe end up working out quite the way you wanted, but enough things went right that you found your path, which is awesome.
Yeah, I think that, most things in life, not everything's perfect, right? But if you can figure out how to navigate around it, I'm pretty agile and I'm definitely a glass half full. I always look for the positive. And so, it worked out for me. It continued to work out. I sit in the CIO chair now and never would have expected that in a million years. I didn't think that I'd go to nursing school to be leading technology.
No, that's so cool. And I know you've had your hand implementing quite a few Epic systems since then and configuring workflows and optimizations and such. I'm really curious to understand, how do you see your nursing background shaping the work that you're doing today as a digital leader?
Yeah, I think it has added significant value to my ability to serve in any of the roles that I've had. It's influenced my perspective and approach on how patients and providers are impacted by technology. I had the intimate understanding of the day-to-day challenges that they face because I've provided direct patient care, and I understand that technology can either hinder or it can enable. And sometimes when it's just led by a tech leader that is very tech-centric and not clinically centric, that the user who is using the tech is often impacted, and then ultimately the patients are impacted. It helps emphasize the importance of developing tools that enhance not only the quality of care that we provide, but the patient outcomes, and gives me a perspective to see It's not just the cool, shiny object, but how are we going to use it and how does it connect to our strategic vision at the organization? So I look for solutions that are intuitive, solutions that can be designed in diverse ways to serve our patients, to serve our caregivers, particularly those that are underserved or in vulnerable situations. And I think that there's a significant amount of pressures in the clinical workforce, and I can understand those and relate to those, and, making sure that I implement technology in the right way. So not, every tech is not implemented the same way. And I think I can implement technology in the right way that, again, helps serve our population and our caregivers and not hinder the work that they're trying to do. There's nothing worse than having a click or a nuisance around tech that inhibits your ability to care for a patient, because that's what they got into healthcare for, was to care for a patient.
Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more.
Terri, can I ask you, is there an example or two where either your clinical background and having the CIO role, because of that, you're able to either accelerate a technology that really was good for the clinical situation, or maybe a situation where you're able to actually avoid or turn off technology because of that clinical experience?
Yeah, I think we'll go with AI because that's kind of like the buzz right now, and everybody is looking for this AI strategy. And I get asked this a lot. What is your AI strategy? I don't really have an AI strategy. I have a tech strategy that sometimes has AI in the toolbox, and sometimes AI is not appropriate. And when you're looking at introducing tech into your ecosystem, you really have to look at what is the problem you're trying to solve. And I think a lot of clinicians are known for this too. They go to a conference or they see this cool demo and the vendor promises all of these things and they're going to solve your problems. But we don't even know that we have that problem, but we like the way that it looks kind of shiny or that it's kind of cool and we want to introduce it. And so I think really understanding, what's the problem you're trying to solve. And I'll use the example of we've introduced Artisight into our ecosystem. It is an AI-enabled computer vision that helps us with our pulse center, which is kind of a centralized command center. And it was not received with open arms initially because it's a camera. People don't like to be watched. So the nurses thought that they were going to be watched for a punitive reason or that we were going to replace them with AI. And that's not even feasible, to be honest, but it's just not what our goal was. Our goal was to help our patients reduce falls that they were having. So with the cameras, we were able to cover or watch 16 patients versus with one person versus 16 people with 16 patients. And that allowed us to cover more patients. And that allowed those other 15 people to actually provide the hands-on care that they were trying to do or that they got into healthcare for. And then, we expanded that into a virtual nurse program to assist all these new nurses that are coming out and taking the jobs of the nurses that left the workforce because of COVID and now we're short. We were able to look at how do we support them with some clinical care, but not be in the room with providing hands-on care, not to take away. So their ratios didn't change, but their ability to actually care for the patient changed. And so the change management in that, we had to really approach it in a way that showed the value to the clinician and allowed us to introduce the technology that enabled their care. Now we get all kinds of requests like, what can RSI do or what can a pulse center do? And so now we're pulling it back to actually make sure we have good business cases. Just because you can doesn't mean you should kind of scenario. That's a good example of what went well. I think we've had lots of tools in our ecosystem that promise things that weren't necessarily true. And I'm not going to name any vendors, but either some automation or some integration, and the lack of integration was a hindrance. I can give you an example around sepsis monitoring. There was a fair amount of hype around this program being able to serve up and reduce our patients becoming septic. So we would see it earlier and it'll help us with compliance bundle. But the workflow to actually do that was so hindering that we never received or achieved those value within the software. So I think, there's a lot of things that you have to understand, like what are you trying to solve for? And then take it from that approach.
Yeah, it kind of reminds me of how, a lot of times we go to conferences and, oh, there's a new hammer, there's a new screwdriver. And it's like, they bring it to you and you're like, hey, well, yeah, I could take a hammer and everything looks like a nail. You can hammer anything you want, but what are we actually building? Do we have to build anything in the first place? And so it makes a ton of sense. I'm kind of curious for the artist side example. It sounds like a big part of the change management was communication around, what's the real value? How's this going to help you? How's it going to help the patient? Looking back, do you feel like that was something where you didn't do enough at the beginning to kind of set the stage and that changes how you do things going forward? Or do you feel like part of it is, until we actually show that benefit, show that we prevented falls, show that we saved time, it was still going to be a challenge to bridge the gap in communicating value?
Yeah, I think we had pockets, right? So we had individuals who were accepting, particularly like a new nurse who never did a particular procedure before and they had to phone a friend now, essentially. When we first looked at the fall risk and enabling telesitting, we had a bunch of no, we can't do that. We're a very risk-averse industry because at the end of the day, it's the patient, right? So the patient is going to be the one that's impacted if we do something wrong. What we approached it as is, okay, let's take away the no. Let's take away, we can do this, and if it fails, we're going to go back to the way it was. So we've taken that approach of failing fast or learning fast so that we can adjust. With that particular instance, we bought 50 cameras, mobile cameras that went around to all of our facilities. And within 4 days, they were asking, how can we get more cameras? I think that once they see how does this impact me? How does it impact the patient? And they can make that connection. And a lot of times communication doesn't do it unless you're you're actually using it, right? But you have to recognize that. You have to be able to listen and hear their concerns, even if their concerns are invalid, because, you want all of those naysayers to be on your team eventually.
Can I ask you, Terri, about how you think about sustaining the innovation, the transformation you've done? Because when you start something new, it's really exciting, it's novel, people are doing it for the first time, and then maybe you start to see the benefits, but I don't know, a year or two from now, maybe it's embedded in the clinical workflow, but if there's still some effort required to keep it going, people might lose interest, momentum, move on to new things. So any thoughts around what you've learned around how do you sustain innovation once it's been embedded and it's been proven?
Yeah, I think there has to be a culture approach to innovating. And I think also back to that failing, failure is not bad. I mean, as long as we're not hurting somebody, but failure is not bad because it gives us the ability to learn. and to course adjust. But I think, if we start with what are the problems we're trying to solve, you should have metrics that you're monitoring to that. And I think that's another thing that I've been able to help our IT department is that we're not implementing and walking away. We own this long term and the success of that, not just us, but the operational owners too. And, measuring those and kind of course adjusting. Do we need to have additional training? Did we tweak it wrong and we need to add, whatever it is to make it successful? I think, just that kind of continuous improvement. Because what works today is not always going to work tomorrow. And I think also connecting the IT team closely to the mission. If they feel their purpose and, that their work is purposeful, they're going to be more tightly, okay, let's solve this problem together versus an order taker approach where whoever's the largest screamer or the loudest screamer is the one that gets the work being done. That's a transformational kind of culture that has to happen in order to be an innovative team.
Actually, that leads me into the next question I have. Terri, at HIMSS earlier this year, you were on a panel discussing this topic on how to manage a lean IT team. And I'm curious, what are the key takeaways from that discussion? And how does that lead into you finding champions or turning those skeptics into the supporters of different initiatives? How are you kind of viewing the IT's responsibility in those efforts?
Yeah, I think, you need a strong prioritization and focus on strategic initiatives, which means you need transparency, right? So you need to understand the strategy that the organization has put in place. What are the goals? And that could be the long-term strategy over the 5 years, because that's typically what most organizations do for a plan, versus the year-to-year goals. But if you're tied to that, then you can focus the efforts on the things that you're trying to do that aligns to that. We do have a very strong governance process where we not only track what our team is working on, but what is our demand versus capacity, so that when we are approached by the organization for a new project, we can look at it from, is this aligned from our strategic initiatives? Is this aligned to, patient safety? Is this a regulatory kind of requirement, those kinds of, or a financial requirement? But then we can show our capacity to complete a project using data. And when we transition to that, the relationship between IT and operations changed because they were given the information to make the decision on when we can do something and when we couldn't. So, just from a heat map, they can look at, oh, it looks like you can't start this till September. And then they can make the decision, do we move something else? Do we give you more resources to complete this? Is it a short-term thing? Or are we okay with waiting till September? And it takes that burden off of IT saying no all the time, which makes a more collaborative culture. And I think, if you don't have collaboration between operations and IT, we're just thought of as a cost center, a barrier. You get identified, they start working in their own silo IT departments and start making workarounds, because that's one thing healthcare is really good at, is we figure out how to work around the problem. I think also, I think I mentioned earlier about transparency, just having clear communication around that. It's really important that everybody's on the same page. And, we have regular communications around our goals and the challenges and, any barriers that's going to prevent us from achieving those goals, so that we can make sure that we involve the right stakeholders at the right time. It's also important to make sure we take care of our people. Since we are a small team, we are a lean team, we're very close. We live in a small community. Everybody knows each other. Everybody knows each other's families. And so it's really important that, we don't have burnout on the team, because if they lose that connection to the mission, if they lose that connection to their team members, you're just going to lose them. And then for me, it's really hard to recruit new members just because of the area that we serve in. And I think it's also important to maintain good relationships with our vendors and really identifying vendors that become partners and not just somebody who's trying to sell something to you. Because when you have a partnership, you can work off of each other and maybe they can help you or leverage some of their external expertise to help deliver, anything that you're trying to implement. And I would say Epic's a good partner, Intersite's a good partner, Microsoft's a good partner. And when you form an ecosystem full of partners like that, it's just an extended family.
I think one of the big takeaways I had from this conversation is that when you talked about the transparency of the data between teams, it kind of made me think about how, like, imagine like the clinical teams were going to the IT team requesting stuff, and if IT was just always saying no, and that was all you were saying, clinical just doesn't understand. They're like, well, they're just always saying no for no reason. But to your point, when you're sharing that context, the data around our capacity, our resources available, clinical folks realize, okay, with this context, I totally understand the limitations and how that might impact how we think about IT capacity. But you have to put in that effort to share that context, get the data, distribute it. It takes real work, but it actually makes the collaboration that much more effective because they can actually understand what's going on. And it's not just a no, it's like it might be a no, but there's a really good reason around why. So that makes
no,
sense.
but, so it can, I think also one of the things that we've really tried to change the culture is to not be, we're not an order taker. And so we're not going to say no either, but we're going to collaborate and say, what are you trying to do? Because a lot of times we don't need to implement a new tool because we have something either available in our ecosystem or Epic can do it, or, maybe it's already there and they don't even know. So I think sometimes it's just education. I tell my team that we're educators, we're the subject matter expertise. We need to give them the data that they can make sound decisions. Now, sometimes we make sure that we guide them to a good decision. But we typically don't say just outright no. Well, we try to collaborate and figure out a solution.
Love it. You mentioned earlier that like you view AI more as a tool in the toolbox as opposed to, a single solution for everything, which I think Al and I are totally on the same page with. So I think a fair question to ask would be, what does excite you about AI in the next couple of years? And then also, what are things that you feel like they're kind of overhyped? And especially with your clinical hat on, you have to be a little bit more thoughtful about.
Yeah, I think, AI has been around for a really long time. It wasn't until ChatGPT, when it became more humanistic, that it's really gotten this hype. I think we're now at the point, though, with the technology that it's really going to have strong use cases in the clinical setting. The ability to kind of collate the data and give you information real time is going to be really valuable. I think, predictive analytics is something that is an easy win. It's data you already own. If you can kind of mine it, you can look at staffing, you can look at whether a person's going to be readmitted or if they're available to be part of a particular program to help them manage their care outside of the hospital walls. But I think what's really going to be exciting is when you continue to look at care model redesign on how you can supercharge a nurse with AI or supercharge a physician with AI. It's going to really change our ability to care for all kinds of patients. And I think that that's really exciting. I think the overhype is that it's going to be, able to replace a nurse or replace a physician in their ability to use critical thinking to, navigate the diagnosis. Like, it's not going to diagnose and, everything's going to just come out of AI. That's just not the way it's going to happen. I think, most people still want this human interaction. And there's a certain level of empathy that comes from having direct interactive care and just critical thinking to know. I mean, it should be supportive, but it won't take over the world.
Yeah, it's almost like I like what you're getting at with the idea that AI more of as a co-pilot for clinicians in clinical care. It's almost like giving people superpowers to just care better, faster, have more leverage, as opposed to just, an AI agent. I mean, I think it's fair to say, like, we can have AI agents for very simple automated things, like maybe self-scheduling, for example. But when we're talking about complicated, complex patients with multiple comorbidities and navigating their care, it's like, that's a very different situation than self-scheduling.
Exactly.
With an agent. Even beyond the AI stuff, like you've been a fantastic leader for the broader digital transformation at Guthrie. So major leap from 2 to 10 gold stars with Epic. That's a big jump. Congratulations. We talked a bit earlier about change management. Were there one or two specific change management strategies you felt were most important in making that major transformation?
So when I was first hired at Guthrie, the CEO at the time said, my physicians are saying that they're leaving Guthrie because of Epic. I want you to fix it.
Mm.
So that's what started what ultimately ended up us getting stars 10. And we've maintained that for, this will be our 5th year this year. But what it did was it gave us a roadmap. So when we started looking into why physicians were leaving, it was that lack of collaboration. We had the Cadillac, but we never turned on the heated seats. We never used the lane things. We didn't use any of the features, because what was happening behind the background was the IT team was taking, they would look at the upgrade and they would say, I don't think nursing is going to do this. And they might do this, but physicians are never going to do this. And so they picked and choose what we turned on. We were also an early adopter, so they implemented in 2003. So they had some highly customized workflows. So we took the approach again, we're going to pull in the users, we're going to educate, we're going to take everything unless there's a compelling reason not to. There's some regulations and stuff, particularly serving in New York State. They're a highly regulated state that we can't do certain things, but we were taking the approach, we're taking everything. And we looked at where our gaps were and put a roadmap to do that. And it was just project management. It was just strong project management and aligning what we were trying to achieve was to make our physicians happier with Epic. And in order to do that, they had to have the tools that were, more personalized and user-friendly, like setting up all their preference lists and making sure that they had quick buttons and all those things that we didn't do before. That was the reason. So again, when I talked earlier about, understanding your why, like what's the problem you're trying to solve? That was the problem. And then we had to align it to our IT team to understand, and operations, if there was an investment, to understand, and the path to get there. And we're very proud of the stars 10. I think that we're one of a few organizations that will have achieved it 5 times in a row. And so, we're very proud of that. But the ultimate goal was to make our physicians happier with Epic. So I think, change is personal, but most of that change actually was on the IT team.
Very interesting. I'm curious, how are you going about educating different people on tools that already exist that maybe they're not leveraging, or different functionality that's now been built? What's your kind of 1 to 2 kind of key strategy approach to educating the team?
Well, particularly around Epic, I mean, they've made it fairly easy. They have a signal, which is usability essentially for clinicians, and it takes it down by the department to even the individual providers, and we can actually see what they're using well, what they're not. We have credential trainers that they round all of our offices on a regular basis. So that's their touch point. That's their IT person. When the office sees them, they know that they can ask their questions. But they also use that data. They develop individualized plans so that they can make sure that the clinician is maximizing the product. But for some other products that are not as easy to get the data on, we do use a fair amount of marketing, does a lot of our communications. And I'll use Tiger Connect as an example. We're moving to a unified communication platform. We have multiple communication platforms today, and everybody gets married and very emotional about their devices. And so, again, change is personal. What does this mean for me? How does this work? And so we've taken the approach that we involve them in the conversation. So Vocera is something that the nurses use. It's hands-free. We are looking to replace that, but we're talking through it with them. Like, okay, well, if, it's a task force, this is how you use it today. This is how it will be implemented in Tiger Connect. What's the barriers? And so I think it's the approach of understanding, again, listening and trying to make sure that we address all the concerns, because my view is, well, you can do it on Tiger Connect. That's easy. Just pull it up on your phone. But their view is, I'm in a patient room and I can't use my phone in a patient room, right? So there's this disconnect if we don't communicate. So lots of communication, I think you can't over communicate. You have to say it lots of times in many different forms. But we also do round a fair amount, including myself, to make sure that I see how they're using it, ask questions. They usually see me and they tell me about all their desktops that are broken. But the idea is to form that relationship so that we can make sure that they get the help they need.
I love that. So you're not just putting on a baseball cap and going undercover and they don't know who you are.
Yeah, I know. I'm the only Couts here, so I think it's really hard to be undercover.
Yeah, that's funny.
But actually, it's a great. Someone should do Undercover Cop for health systems. That'd be kind of funny.
I know the operations used to do like a secret shopper. It was like patient, like they would call it and pretend to be a patient. To get an
I love
appointment,
that.
that kind of
I
stuff.
love that.
Yeah, really cool. So, Terry, another hot topic in healthcare always is cybersecurity. And I know that you've likened explaining its importance to providers to telling a teenager not to use their cell phone while driving. Obviously not going to happen. So I'm curious, what strategies have you found to be effective in communicating that it is a shared responsibility for cyber risks beyond the IT department?
Yeah. I think honestly, most recently, it's been easier to communicate that just because of the amount of impact that it's had on even our health system. So we acquired a hospital that was a divestiture from Ascension and was still using their systems when they were attacked, and seeing the downtime and the impact of not being able to use technology. They were down for about a month.
Well,
and, when you think about, well, you could just place an order in and the lab gets it, they result it, everything happens. Now you're taking a written order, running into the lab, waiting for the result, running it back. And the complexity among that and the risks that it takes, I think that they feel it very personal. We do a fair amount of phishing campaigns too. I think most events that are introduced into healthcare's ecosystem is by clicking on the wrong link. And we educate when they fail. So if they failed tests, they have to take an education right away. Many people are really ultra paranoid right now. But I think that the new kind of risk is social engineering, where people are pretending to be individuals. And we've seen a fair amount of that as well, particularly in our help desk. And so we've had to put some really stringent identity processes in place, which is a barrier to a clinician getting their work done. And, we just educate and communicate that on a regular basis, because there are individuals who all they need is, they just have to be right once, right? They need one link in, and then they got the keys to the kingdom. And so it's a program. It's not something that is a one and done. I remember just having a conversation with one of our physicians when he's doing a research, and some of the cyber requirements that we were asking the vendor to do, they didn't want to do. And he was, this is 5 patients. It doesn't even hit the threshold for a breach or for HIPAA notification. But when I explained to him, I'm not concerned about HIPAA. That's our compliance officer concerned. I'm concerned about one time a person gets into our network, and it only takes once, and then it's spread across. And just having those conversations and trying to be proactive and collaborative, and how do we I know you're trying to do this, but how do we get there without circumventing our processes?
Yeah. Yes. Cybersecurity is one of those things where it's like, unfortunately, until something bad happens, sometimes we just don't realize how bad it could be. But you also don't want to experience an event in the first place, right? So you have to somehow convince everyone this is important without hopefully ever getting to an actual event, which is just very, very tough job to do. I mean, for me, it's gotten to the point where I won't even pick up the phone if I don't recognize the number or name. But then people can spoof now. So I don't know. I mean, I just will never pick up the phone at some point in the future. I don't know.
Yeah, it goes back to the car and child with cell phone. I mean, there's no kid that thinks it's going to happen to them. That's why it's, but and now it's happening to more and more of our friends. And when it becomes real, I think people start to listen.
You mentioned earlier, some of the education you're doing around how to avoid being phished and all that, and then maybe you get a course if you fail a test. Are you actually doing random fake phishing tests?
We are, yeah.
Oh wow. Okay. So if I get a random email, yeah,
and we do it around key events. So there's things that are identifiable in the email that you would have got that should notify you that it's a phish. But we do try to trick them too. I mean, it's not meant to be an easy task. We want them to look at every email. We don't want it to be easy.
Okay. That's pretty smart though, actually.
Yep.
Yeah.
It's good to hear you're not just picking on cardiology and
Yeah. And it is random, so I get it too. But we just pick a random set of users. We measure the outcomes so that we can see, is our education effective or not, so that the next time we can address it.
Right.
That's smart.
Fascinating.
Yeah.
Well, Terri, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. So just 5 rapid fire questions for you. The first question we have is, what is your favorite book or book you've gifted the most?
I really like Never Split the Difference. It is by Christopher Voss. He's an FBI agent that was a negotiator and talks about his methods and approaches to negotiation, and you can apply it in kind of any setting. But it's real world kind of scenarios, which, is easy read, kind of a fun read, but has some professional takebacks from it as well.
Mm-hmm. Yeah, I love it. Question 2, who is a person either dead or alive who you'd love to meet?
Supreme Court Justice Ruth Ginsburg.
Oh, yeah. Awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
I think this one's tricky, but I would say I would say super strength.
Okay. Yeah. Question 4, what is something in healthcare you believe that others might find insane?
I think that the idea that hospitals are no longer going to be, that we don't need to build more hospital beds. I think people think that that's insane, but I really think that that's going to be true.
Yeah. Cool. Last question. If you could travel back in time to any event or moment in history, what would it be and why?
Oh, any event. I would say I love the Renaissance era, so I like medieval time. I like watching, House of Dragon and like all those shows. So probably that, just because I like the way they dress.
Yeah. Awesome. No, I love it. Well, thank you, Terri. That's unfortunately a wrap for this episode of The Digital Patient, hosted by Seamless MD. But we really appreciate having you on today and sharing your wisdom with our audience. If you like the show and you want to learn more, visit www.seamless.md. Terri, Ms. Couts, again, thank you so much.
Well, thank you for having me.